So let's continue our discussion on hemoglobinopathy. So in this lecture, we're going to focus on thalassemias. So in normal healthy individuals, we typically generate an alpha chain and a beta chain in such a way that we always have a one-to-one correspondence. So an alpha chain is always paired with a beta chain, and we generate the normal hemoglobin A molecule that consists of two alpha chains paired with two beta chains. And this conformation gives the molecule the ability to bind oxygen in a cooperative fashion. Now, if we have a problem in generating alpha chains, this is known as alpha-thalassemia. If we have a problem generating beta chains, this is known as beta-thalassemia. So let's begin by focusing on alpha-thalassemia. So if we look at chromosome 16 actually has two genes that code for identical alpha chains. And because we always have a homologous pair of chromosomes, one from mom, one from dad, we actually have a total of 4 genes that code for alpha chains. So for example, on one chromosome, we have alpha 1, alpha 2. On the other chromosome, we have alpha 3, alpha 4. So a total of 4 copies of alpha genes are found in a normal, healthy individual. Now, what happens if we have a mutation in one of these 4 genes? Let's suppose alpha 4. Well, we still have 3 fully functional alpha genes, and so that's enough to actually create enough alpha chains. So these patients are known as silent carriers of alpha-thalassemia, and they actually have no clinical findings and no clinical symptoms. So totally normal, totally healthy. Now, what if we have a mutation in 2 of the 4 genes? This is known as alpha-thalassemia trait. And these patients, although they will have some symptoms of microcytic hypochromic anemia, these patients are overall healthy and normal. So we have 2 types of mutations of alpha-thalassemia trait. Either the 2 genes that are mutated are found on the same chromosome, and that's known as cis, and this is commonly found in the Asian population, or we can have trans, which is found in the African population, and this simply means the 2 genes are found on opposite chromosomes. So again, the silent carrier, no symptoms at all, fully normal. If we have 2 mutations, that causes alpha-thalassemia trait, again, pretty much normal, minus the microcytic hemolytic anemia. And so actually, this is commonly misdiagnosed as iron deficiency. The only difference is if you give patients with microcytic hyperchromic anemia secondary to alpha-thalassemia trait iron, that will not actually help their symptoms, unlike an iron deficiency, which will help the symptoms. And finally, the more severe cases are shown here. If we have mutations in 3 of the 4 chains, this will only leave 1 fully functional alpha gene. And so we're not going to be able to generate enough alpha chains, and so these individuals actually have a tetramer of 4 identical subunits, either the gamma subunits found in kids and infants, or in adults, we're going to see beta tetramers. So the gamma tetramers are known as hemoglobin BARTs, and the beta tetramers are simply known as beta tetramers. So earlier I said, because we have 2 alpha chains and 2 beta chains, the normal hemoglobin A, these heme groups can actually interact well, and that gives the hemoglobin the ability to bind oxygen in a cooperative fashion. But if we have 4 identical subunits, as in hemoglobin BARTs or the beta tetramers, these patients are not going to actually exhibit cooperative binding of oxygen. So even though the tetramers are going to be soluble within the red blood cells, they're not going to be able to bind oxygen, or at least they're going to be able to bind oxygen with very high affinity, but they're not going to be able to release that oxygen. And so that will cause problems in actually delivering that oxygen to the tissues. And finally, if we have mutations in all 4 of these alpha genes, well, this is not compatible with life. And that's because hemoglobin actually needs alpha chains. And so these patients develop a condition known as hydrops fetalis during fetal development, and that actually causes fetal death. Now let's move on to beta thalassemia. So here we saw that we actually have 4 copies of the alpha genes, but we only have 2 copies of the beta genes. So one is found on chromosome 11 and the other one is found on the other homologous chromosome 11. So normally during fetal development, we don't actually use beta chains. Remember, we use alpha chains and gamma chains in fetuses. And so that's exactly why, since defective chains are not actually expressed until late in fetal development, symptoms and signs of beta thalassemia doesn't actually arise until after birth. So we have 2 types of conditions. We have beta minor and we have beta major. In beta thalassemia minor, we have a point mutation in one of these genes, knocking out only one of the genes. So because only one gene is knocked out, we still generate a good amount of beta globulin. And so these patients are relatively asymptomatic, but they may have microcytic anemia. And the way we diagnose this is we do electrophoresis test and we see hemoglobin A2, and this consists of 2 alpha chains and 2 delta chains. Now, the much more severe case of beta thalassemia is if we knock out 2 of these genes, so we have no functional beta production. And so these infants are typically asymptomatic because remember, infants actually use gamma and not beta globulins. And so infants are typically asymptomatic at birth but will develop severe microcytic anemia during their first or second year of life. And these patients, to actually survive, require continual transfusions. Now, initially, these transfusions are life-saving, but eventually they can actually cause a buildup of iron in our body and tissues. And this is known as secondary hemochromatosis. And this can actually be lethal, and it typically causes death anywhere between 15 to 25 years of age. So what other symptoms are we going to see and findings are we going to see in patients with major or beta thalassemia major? Well, basically, these patients will experience bone marrow expansion because they're going to have severe anemia, and their bone marrow is going to try to produce as many red blood cells as possible. And so we see the expansion of bone marrow. And so this can actually cause facial and skeletal abnormalities. And so on x-rays, for example, we're going to see crew-cut appearance of the head. And we're also going to see this characteristic chipmunk facies. Now, eventually, the bone marrows are actually going to fail, and our liver and red blood cell and our liver and the spleen, they're going to take over the production of red blood cells. And so we're going to see expansion of the liver and expansion of the spleen, thereby causing hepatosplenomegaly. In addition, because the spleen is affected, infants or patients with beta thalassemia major who are infected with parvovirus B are actually going to have an increased risk of developing parvovirus B19 induced aplastic crises. And the last thing I want to talk about is many of these patients with thalassemia, we're going to see target cells, which are these abnormally looking red blood cells on the peripheral smear. But we can also see target cells in other conditions, for example, liver disease, hemoglobin C, as well as asplenia. And a good way to remember, and a good acronym to remember all the conditions you see target cells in is HALT. So H stands for hemoglobin C, A stands for asplenia, L stands for liver disease, and T stands for thalassemia. So to summarize, thalassemia is a very common type of hemoglobinopathy in which we either have a problem in producing alpha chains known as alpha thalassemia, or we have a problem in producing beta chains leading to beta thalassemia.